introducing our healthcare moderator, Robin Dozier Otten. She's done a lot of work in New Mexico for many, many years, has fought hard, and I want to just read, she has a very, very impressive resume. But more than this, it's her heart and passion for New Mexico and seeing it turn around. As we started working on this conference, Robin inputted so many great things, and the reason why this conference is going on is because of her hard work, and many others, but I really do appreciate Robin's hard work. But Robin is the president and CEO of RDO Strategic Consultants, a public issues consulting firm founded in July 2003 in Albuquerque, New Mexico. RDO Strategic Consultants specializes in campaign consulting, grassroots lobbying, and issues management. Robin has served 8 years on former New Mexico Governor Gary Johnson's cabinet, first as Regulations and Licensing Department Superintendent, and later as Human Services Department Secretary. Previously, Robin had been in the private practice of law at Otten, Vogel, and Campbell, PC, a firm she founded in 1987. Robin is a graduate of the University of New Mexico with a BA in government and received her law degree in 1981 from UNM Law School. She's a mother of 2 adult daughters, Elizabeth Otten Hepworth and Amy Otten Staples, MD. RDO Strategic Consultant serves as the director of the New Mexico Prosperity Project, one of our sponsors, a nonpartisan joint effort between New Mexico employers and state and local business organizations to encourage more active and informed participation in the government process. Please give a warm welcome to Robin.
Thank you very much, Ryan. What nice things you said, and I appreciate them. I'm going to set the stage for our panel, who are the real experts at this. When I came to the Human Services position in Santa Fe, I really had no background in healthcare. But it's the baptism of fire when suddenly you're responsible for a $2 billion a year portion of our state budget in the Medicaid division. And I learned about it quickly, and I really enjoyed working in that area. But I certainly would hate to see our government take over all of our health care. So that is the perspective from which I come up front. As America's population ages, health in all its dimensions is a critical component of our economy and vital to our workforce. The New Mexico Prosperity Project supports policies that reduce mandates, encourage innovation, and foster marketplace reforms. We encourage ideas designed to reduce costs while creating opportunities for health insurance coverage that previously did not exist. Because we believe it will create downward pressure on costs while offering families and individuals health care coverage better suited to their individual needs, we support a gradual migration from an employment-based insurance model, as we have today, to an individual-based market. In the meantime, policy reforms should create employer innovation, limit litigation that increases costs, and strenuously resist efforts to prescribe one-size-fits-all government coverage. And with that, I am going to introduce these very qualified members of this panel, and I'm so grateful to all of them for agreeing to be here with us this afternoon. Mike Dobbs is a native New Mexican, born and raised in Carlsbad. He graduated from Yale University in 1972 and had a 33-year career with a major health insurance company, during which time he lobbied Henry Waxman, Keith Stark, doesn't get a lot better, Jerry Lewis, and other members of the California congressional delegation against the Clinton health care plan. He retired to Taos in 2005 including the Taos think tank, a conservative discussion group dealing with issues such as the current healthcare debate. He is married to his wife of 39 years, Sylvia, and has 2 grown sons and 2 grandsons. It's pretty fun being a grandfather, isn't it?
Yeah.
Next, we're very privileged to have Dr. J.R. Dameron. Dr. Dameron is a practicing diagnostic radiologist with Santa Fe Radiology, with board certification in radiology and nuclear medicine. He has been associated with numerous professional organizations, the AMA, the Radiology Society of North America, American College of Nuclear Physicians, and the New Mexico Medical Society. He has received many national and local awards for professional and advocacy service and serves on multiple state committees and task forces. He has been the treasurer of the Santa Fe County Republican Party, serving on the executive committee for the county and the state, along with the state central committee. He was a national delegate in 2008 to the Republican National Convention and was the Republican candidate for governor in 2006. He believes that community service is an important aspect of commitment to society and has served on many diverse national and local boards. He is married to Barbara Dameron, who is an oncology nurse with a PhD in psychology and a cancer researcher at UNM Cancer Center. They have 2 children, Matt and Allie, who are in college at the University of Denver and New Mexico State University. And finally, we have Devin Day, and thank you, Devin, for being here with us today. Devin specializes in financial strategies for individuals and small businesses, including insurance planning. This includes life, long-term care, disability income, and health insurance. She has partnerships with several excellent brokerage managers to aid in complicated cases, such as premium finance. Devin graduated from the University of Virginia McIntire School of Commerce in 2000 and established her financial and insurance advising practice in Albuquerque 9 years ago. She completed her Chartered Financial Consultant designation in 2007 and is currently working on her Certified Divorce Financial Analyst designation to be completed this year. Devin is involved with the following organizations: Vice President of the Albuquerque Academy Alumni Council, Treasurer of the Society of Financial Services Professionals, Treasurer of Chamber Music of Albuquerque, Vice President of a Child's Garden Preschool, volunteer mentor with Acción New Mexico, volunteer with LIPA program with Cancer Services of New Mexico. As you can see, this is a diverse and very talented panel full of expertise. And now I would like to turn it over to Mike Dobbs for his presentation.
Thank you. A couple of comments. Number one, being at a conference that's sort of headlined by Jonah Goldberg and John Fund was quite a thrill to my son in the Washington, D.C. area who attended the Tea Party over the weekend, and despite the Dallas Morning News estimates of 30 to 50,000 people, assured me that there were in excess of 1 million people. He quit counting at 458,000 because he could see that there were at least another 475,000 or so behind him, and so he stopped counting at that point. It was a great experience for him. Equally, my son on the West Coast, who's a musician, performing musician, was impressed by Jonah and John's names by saying, "Who?" So it's a thrill for me to be here. A couple comments about the Taos think tank. It's a group that started sometime after the last election. We had a very aggressive, independent, non-Republican who was trying desperately to get messages about fiscal issues, tax issues, and so forth to the local and to the state and to national parties, and had little success. And he got frustrated and said, we ought to start a grassroots thing and do something from the bottom and use the internet to get out and try to get some issues discussed, evaluated, and shoot some ideas out. So that's what we did, and it, just by happenstance, healthcare was the first issue that came along. And having had the pleasure of dealing with Senator Waxman and his staff, and Pete Stark and his staff during the Hillary Care discussions in the early 90s, I took a little bit of lead on some of the issues, but we had a group of about probably 12 to 15 people that had participated in just a discussion, and we thought it was a good idea to come up with something. So we decided we ought to start with sort of what the premise is, and the premise is to provide insurance to an estimated 47 million uninsured individuals without destroying the programs that are covering 250 million very successfully and very popularly, be they government, Medicare, Medicaid, or the private sector. Now, uninsured is an important term here because it must be noted that all 300 plus million people in the United States do have access to health care. The unfortunate thing is 47 million of them have access primarily through the emergency room, which is the most expensive access point to go through the healthcare system. And so that's a point that needs to be made. Next slide. In terms of the uninsured, we need to break these down in different groups because there are different issues and different potential solutions depending on the group. Undocumented aliens represent 12 to 16 million. Eligible for Medicaid and the SCHIP children's programs, but not enrolled, are about 8 million children and roughly 3.5 million adults that are eligible and not enrolled. You have a group of people that are primarily in their 20s to early 30s who choose not to be enrolled, and there's also, in that uninsured by volunteer category, some people who make a pretty decent amount of money who just choose not to pay the health insurance coverages that may be available to them. And then you've got another 9 million or so that are temporarily uninsured. They may be between jobs. They may have chosen not to take their COBRA if they're eligible for that, etc. And then we've got a group of roughly 8 million that really do have an issue and really do fall through the cracks. And those are the people that may have a pre-existing condition or may have lost their coverage because of their employer and are unable to get insurance because of that pre-existing condition. One of the major arguments for the healthcare debate in this country is that the American healthcare system is simply too expensive. We don't get enough for it. And, the biggest issue that people hang their hats on is that our life expectancy in the United States is 30th in the world, despite all the money that we spend, as much as 50% more than some of the more advanced countries. But the interesting statistic that gets left out a lot is if you take homicides and auto accidents out, America leads the Western world in life expectancy. And last I heard, homicides and auto accidents were not a problem with the healthcare system. It's a problem with social issues in this country. Secondarily, cancer survival rates in the United States exceed Europe's substantially. Next slide. As you can see, if you're a male in particular, the cancer survival rate for all cancers is about 50% better in the United States than it is in the European Union. And this is 2007 data, so it's fairly current. And that's primarily because we have such a good system here in terms of research, development, etc. Another issue is our research commitment. The reason that we, next slide, reason that we spend more money is because our research commitment. And we provide more than half the $175 billion worth of new healthcare products that are developed globally come from the United States. And we provide 71% of the new drug purchases in the world, primarily because we're developing these new drugs and the American people demand them. So there are a significant number of reasons why even our governmental research is 5 times what they spend in the European Union on an annual basis. So we are committed and we are leading the world in medical research, which is going to drive our costs up. Finally, just some other observations interesting to note. When Italian Prime Minister Berlusconi needed heart surgery, he didn't go to London, he didn't go to Paris, he didn't go to any of Michael Moore's suggested options, Havana. He went to the Cleveland Clinic and has his surgery done there, as did a cabinet minister from Canada who had breast cancer treatment. She went to California to have hers done, and the Canadian healthcare system didn't have enough beds for a woman who was having quadruplets, and she came to Fargo, North Dakota, or excuse me, Great Falls, Montana. Great Falls, Montana, same difference. They're close to Canada, that's the point. And as a matter of fact, last week, a Saudi prince, the crown prince of Saudi Arabia, came here also for surgery when he had access to the finest care in the world. They all seem to choose the United States. I'm not trying to debunk the issues that we have here, but some of the arguments just are not accurate. And certainly the misinformation is coming from somewhere besides those who have an alternative. The health insurance are the problem. That's another one that's out there, and that's why the debate changed from health care reform to health insurance reform, primarily because of the unconscionable profits of the health insurance industry. Private health insurers insure $177 million people in this country. The top 8 U.S. healthcare companies made $8.4 billion a couple of years ago in terms of total profit. The total healthcare spend was $2.4 trillion. Now, I got pushback in the group when I brought this statistic up. And they said, well, what about executive compensation? So I made a couple of assumptions. Let's assume that these nasty insurance companies, in fact, paid their executives an amount equal to their profits. And since this was only the top 10 that we were looking at, and they insure about something close to 60% of the total population of these top 10 carriers, if you assume that the other carriers made an equal amount of money, you're still talking about $25 billion roughly, which is about 1% of the total healthcare spend. So it's not profits that are driving the issues here. There are inequities in the health insurance industry that need to be addressed, but it's not profits. In fact, some of the issues you've seen in the Albuquerque Journal recently about abuses in the healthcare insurance industry are coming from not-for-profits or for-profit entities or not-for-profit entities. For-profit entities for not-for-profit organizations. So it's not the profit motive that's driving things, but there are inequities that need to be addressed. The current, and malpractice reform. Let's look at that for a second. Because malpractice insurance-related costs range from $210 billion, almost 10%, to as much as $865 billion, which would be almost a third of healthcare trend that could be related to malpractice issues. President Obama made an offer last week to do some limited pilots in states that are already doing some pilots. The speech doesn't go near far enough in terms of what needs to be done there. And limiting non-economic damages as a simple thing, if you just deal with that initially, you see incredible changes. Texas, I don't know if Mary Catherine's still here, But since they implemented their healthcare reforms in 2003, there's a 7,000 backlog of physicians trying to get into Texas, and a whole bunch of attorneys are moving to Oklahoma right now. So, the current approach mandates coverage for all Americans through a combination of public or private options. But the ultimate result of these proposals is you're going to see rationing of health care, government management and control of healthcare practices, elimination of individual choice, and for the seniors, cost considerations that may supersede patient and doctor decisions. The government option is, even if it's implemented by triggers, which has not shown up, and when this proposal was developed, there was a lot of talk about triggers being used. If the insurance companies don't achieve certain targets, then triggers would be needed. It's not the model to follow, and you can go through a whole litany, but they point out how well Medicare works, and Medicare works great. Problem is, it's underfunded as we speak. It's gone negative this year in terms of receipts versus outflow, and it's expected to do that. Even the Social Security program is in a similar boat, as you can see from the slide. Insurance exchanges are also not the solutions as they're currently proposed. The plans would be designed by and specified by the government. They do require, in the current legislation proposed, absolute community rating, which means everybody pays the same regardless of age or gender status, etc. And there are some legitimate actuarial differences that can be justified in terms of those things. But if you do that and don't have some kind of mandate, you're going to end up driving out younger and healthier, likely to go to a public option if one shows up, which is going to force people ultimately into some variation of a single payer approach. The think tank came up with a proposal to offer a unified program that we could all sort of rally around as an alternative instead of just saying no to what the current proposals are. But the first thing we thought we ought to do is give us some time to do this. The programs that are out there are not proposed to begin until 2013. So we thought perhaps we ought to have, we came up with a cool term to sound like we were really political and savvy inside the Beltway, an American Healthcare Advisory Board that would have 60 days to basically come up with a plan for success, and then 1 year to develop a full program to outline a comprehensive healthcare plan to go forward. However, it's obvious that that's not going to happen, and so to prevent the wholesale socialization of our healthcare system, it's imperative that we develop a comprehensive alternative, and I'm going to go through some of those elements. First of all, we thought that any program ought to have these elements in it. First off, some kind of malpractice reform. Just the litigation alone, in addition to those numbers I used earlier or incorporated in them, costs about $100 million a year. 1 in 7 medical tests are done for defensive purposes, so that physicians are protecting themselves from lawsuits, defensive medicine. And in fact, 75% of the medical malpractice cases are found in favor of the physicians, and attorneys make a lot of money. And the physicians spend a lot of money defending themselves, or the insurance companies do, that have the malpractice coverage. Second element is to reduce fraud and abuse. It's estimated that 1 in about every $3 in Medicare is wasted, or through fraud and abuse. I heard an anecdote at a healthcare seminar I attended a few weeks ago in Chicago that the Russian mob in South Florida has given up on drugs because they can establish bogus durable medical equipment companies and bill fraudulently to the government Medicare bureaucrats and make more money than they can running drugs. So, and it's a lot less dangerous for them. But in Medicaid, similar numbers in New York, it's estimated that as much as 40% of Medicaid is abuse and fraud. And can you imagine if you just had a small reduction, even the $200 billion a year that they're talking about this costing currently could probably be taken care of in fraud and abuse if we be serious about it. And the President promised to do that recently in his speech, but there's not a track record. And so, in my opinion, you're going to have to do something outside. Hire people that have experience in fraud. Remember, the insurance carriers have got great fraud detection departments. There's even an industry that helps medical groups that may abuse the system somewhat, get around insurance company detection devices. So there's some real opportunity out there. Undocumented aliens, I'm not going to go through a whole lot of this here other than to say the bottom line is they're going to continue to access care through the emergency room, which is federal law, when necessary. It's a terribly expensive way to go. But unless we deal with the entire issue of illegal immigrants, as John said earlier, we're never going to get this issue resolved, and that 12 million of the group is going to be of significant cost issue. There was considerable amount of the California financial crisis that could be attributed to those social programs, and not just healthcare, but all the social programs in California. On those that are eligible and non-enrolled in Medicaid and in the SCHIP programs, how about if we got them enrolled? It's out there, it's simple, it's easy. Enroll them. And if they don't enroll, then how about if we do a simple thing like assign them to a plan, so that when somebody walks into a hospital, they've got some validation that they're going to get paid for the services they have to provide. Some of this is not rocket science or brain surgery. The uninsured, voluntary, uninsured, and again, mostly youth, but some high wage earners constitute between 8 and 10 million of the uninsured people out there. The current proposal would require this group to be covered or to pay a fine. We think that this group ought to be allowed a tax credit or a voucher to elect a low-cost, high-deductible, catastrophic plan, again, provide protection against themselves and the providers that may have to treat these folks. Failure to enroll would result in that person being assigned to a program with those above features. So again, you protect the provider side of the fence here with some kind of an assignment. Temporarily uninsured between jobs. This group, again, I think there's an easy thing to do here to get these folks covered, and that would be to expand the existing COBRA program to any employer-based company, regardless of size. As I understand it, is COBRA still 25 minimum? I think if you've got to be insured by a company with 25 employees, it could be 10 now. But a number of people have the ability to continue their coverage for up to 18 months, 36 months for a family member after they lose their employment. You could modify that by reducing the number of lives to make them eligible, and to allow those people to elect a plan that's not as rich as the one they're likely to have had. So again, I keep falling back on the catastrophic programs, high deductible, provides catastrophic protection, and costs much less. Portability, institute very simply cross-state selling of policies and cross-state portability of policies, so that if you can buy something from California if you live in Arizona or vice versa, that's a very simple thing to have done, other than the McCarran-Ferguson Act that made states responsible for managing insurance programs. And then allow you to carry that policy with you across state lines when you the mandates. Oh, I'm sorry, chronically unable to get insurance. Apologize. Here's another situation where there's a fairly simple way to go, and there are some states that are currently doing some things. Texas has got a high-risk pool for people that may have lost their coverage and have a pre-existing condition. I have a brother that's in that pool. It's a high-deductible plan. Catastrophic benefits, doesn't pay an arm and a leg. And his pacemaker, if he has issues with that, he's got coverage against the catastrophic cost of something going wrong with that. Subsidize those without financial resources by converting the current tax favored status, and this is sort of an underpinning of our total how do you pay for it idea. Currently, if you're in an employer-based plan, the employer gets a tax deduction for your contribution, or their contributions for you, and you as an employee, generally speaking, will get to pay for your contributions with after-tax dollars, and with pre-tax dollars, excuse me. And so you don't have, you get a bit of a tax break there. If you converted that revenue into something that would apply across the board, we don't have a full Congressional Budget Office analysis of this, but we do believe that that will offset, in conjunction with fraud and malpractice reform, most of any cost that this program would have. Mandates. Next slide. In general, our group doesn't support mandates either at the employer level or the individual level, not only because there's a constitutionality question of mandating either at the individual or employer level, but also the uninsured do access things through the hospital emergency room. And again, I go back to that simple idea: develop a subsidy, tax credit or voucher, whatever the case may be, for those that can't afford something, and make it consistent across the board, whether in an employer program, an individual health care program, whatever, that would give you the opportunity to buy something. And I advocate this high deductible catastrophic thing because it's less expensive, but there are people that do have expenses, and there are limited benefit programs out there. There are companies that will sell $3,000 worth of benefits a year, for example, that gives you a $10 copay at the doctor's office, or $15, that gives you access to some preventive and wellness type programs. Those could be combined into probably a fairly cost-effective and attractive program. And you may talk about that, Devin, when you start talking about what you're doing. One of the real issues that I haven't heard a whole lot addressed is what happens if we put 47 million or 30 or 25 or whatever into the current system. We don't have sufficient physician access today. And so we have come up with just a number of brainstorm ideas: develop a health provider inventory, allow physicians who may be retired to practice part-time, but in order to do that, what keeps many of them from doing that is the malpractice cost is way too high. Consider expansion of retail health clinics, and I'm going to be interested to hear what JR thinks of those, because this has an impact on him and his counterparts. That expand the use of physician assistants, nurse practitioners, potentially midwives, other professional practitioners. Again, it needs some kind of malpractice or government indemnification provided to allow that to happen, but that's the only way I can see that we can deal with this. The other thing is to try to drive people back into primary care, and you could do that through the use of some kind of forgiveness program if somebody would serve in an underserved area like we are in Taos. or in inner cities where you have a tough time getting people, forgive 20% of their medical school liabilities when they come out, government loans, etc. So those are some of the things that we thought about. And then tap the Medical Reserve Corps, which is something that was set up under the Bush administration. That's got a couple of 100,000 practitioners involved in that work on, at the border sometimes. They work in emergency situations now, and there's a real resource to use up there to help expand access. Other considerations, end-of-life care. There is, in fact, an opportunity to affect the quality of life and the cost of end-of-life care through the use of hospice programs and living will instructions, etc. But it needs to be done only by patients, physicians, family members. Doctors don't need to be incented to have a conversation with those people at the end of their lives. And I'm not calling them death panels, I'm just saying there's a way to do that. It exists currently, and we ought to allow that to continue. Probably one of the most important things that we finally came up with is anything that you do ought to be done incrementally. And these things that I've outlined below could be done very quickly with little, no, or even positive cost impact. Implement malpractice reform, focus on eliminating fraud in Medicare and Medicaid, develop these high-risk pools for people with pre-existing conditions, eliminate the inequity of the current tax treatment of employer-based plans so that everybody can have access to something without consideration to their employment status. We had some other radical thoughts. Our founder of the Taos think tank is a big advocate for eliminating the cap on Social Security, reducing the amount that everybody pays as a result of that, which has the effect of taxing essentially higher paid individuals, redistributing some income. So that's not exactly the most conservative idea in the world, but it's something that's come up, and it ought to deserve some kind of consideration. We talked about that when there looked like the single payer thing had some legs, you can get there pretty simply by enrolling every pregnant mother in a federal single payer plan. When she becomes pregnant, include those children, and then within about 3 generations, you effectively got a single payer plan. We decided to modify that a little bit and say, why don't you do that to make sure that you get the children and the mothers insured by putting them in Medicaid until they become eligible for it and get into a non-Medicaid sector. And develop self-insured programs at the local basis or statewide basis. I know JR is going to talk a little about the Health Insurance Alliance, to allow us to fund these things properly and give us, a real option. The final thing is we've sort of had a call for slogans and so forth to kind of say what we want to say, and I'm proud to say these were prominently displayed in Santa Fe from some of my Taos associates. No feds in our beds, and hear our voices, keep our choices. So that's what we think about up in Taos all the time, so glad to hear what you guys have to say later on. Thank you.
Thank you very much, Mike. That was really interesting, and we appreciate all the work you've done on it. And speaking of work, Dr. J.R. Dameron has done a tremendous amount of work on the healthcare exchange program. He has worked with legislators in our state legislature and has some interesting insights to give us on that subject. J.R.?
Appreciate being here today to expound upon this information. I think that Matt Spaulding, from the Heritage Foundation, he really kind of set it up pretty well. What we need to understand is some of the history. How did this all come about, and why are we where we are at this present time, whether it's in the state of New Mexico or on a federal level with the current legislation. All this is very timely. So I'm going to give you about 15 20 minutes of continuing education here. So strap on your seat belts and we'll go through it kind of quickly. 1960, Federal Employee Health Benefit Plan was formed. 8 million federal employees, the retirees, the congressional delegations, they all get their health care from the Federal Employee Health Benefit Plan. TennyCare, Bingaman, Udall, they're all part of this group, okay? This is like a big exchange. What it does is there's 200 plus insurance companies. They have all their products, they have their prices. There's the defined benefit or defined contribution. So what they do is they say, we're going to give you so much money. You go in and you choose. You, as a retiree, you as a federal employee, you as a congressional delegation can go in and choose what you want, okay? So this instills competition with the insurance companies to provide, and usually with competition, you get a lower price and you get a better product, okay? So that's 1960. The Heritage Foundation, then, what they did was, they've been looking at this for some time. The people at the Heritage Foundation, Bob Moffat, Ed Hasselmeyer, Karen Hederman, all these individuals that I'm intimately involved with now are looking at how to get competition in the marketplace in a consumer-driven way without the federal government being involved, but letting the states do it, okay? The Heritage Foundation was instrumental in writing the legislature for the Massachusetts plan. They're looking at 22, 23 other states as well. New Mexico happens to be one. But how I got involved was, I was running for governor. I got out of it in 2006. I thought, Barbara and I, my wife, felt that the best thing that we could do is health care. What can we bring to the Republican legislature, the Republicans in the legislature for health care to go against what Richardson was doing? So we researched the universe for about 3 to 4 months, put the whole thing together, gave a 5-point program to the Republicans there, and one part of this was the health insurance exchange. And the idea of the exchange, as it is, whether it's in New Mexico or Utah or Massachusetts or South Carolina, Colorado, New Hampshire, all these different states are looking at the same thing, is to have one-stop shop. Those individuals, those insurers who are doing business with the state, and it's all regulated by the state. You know, in our state, it's the Superintendent of Insurance, which is Mo Chavez. They regulate what you can sell and what you can't sell. All right? All these would be in the exchange. It's kind of like a farmer's market. It's like a stock exchange. It's like a clearinghouse. What it does is they have all the products there. Make one phone call, or you get on the internet. You decide as an employer, as an individual, as a broker, what's best for this individual or this group, okay? And you choose based upon that. But instead of having to call, let's say, Loveless, and then you have to call Presbyterian, or you have to shop around for the best price. It's all laid out, okay? So what the idea of the exchange is, all the products are there, all the costs are there. It would be portable insurance that an individual could take with them. And then that gets into, should be individual coverage, should be group coverage. So I mean, there are different ways to look at this. And the idea is to inform competition. What the Heritage did then was in Massachusetts, when Mitt Romney was there, is they would bring forth the legislation, and they wanted to work something out. They had a special case though. They came at it from a different angle. They had $431 million in Medicaid funds that if they didn't spend, they were going to lose. So they were geared toward what can we do with these funds, okay? And that was through a special waiver that they had gotten. So they set up this exchange model. Then it was kind of like the Democratic legislature there in Massachusetts. It was like a Christmas tree. They kept adding things on. They wanted an employer mandate. Romney didn't want an employer mandate. In fact, he vetoed it. But because it's a Democratic legislature, they just overrode his veto. And that's how that occurred. Now, they've had problems. They had premium assistance for the Medicaid population, for those on public assistance. And when I say Medicaid, I'm talking about public assistance in some manner. Could be Medicaid, could be S-CHIP, could be SCI, which is in our state coverage initiative. That's all federal money that comes into the state. So that's what happened in Massachusetts. And unfortunately, their costs have kept rising and have gotten up pretty high. So a lot of people are not using the Massachusetts model. Recently, Utah was another model that was used, okay? And they're coming at it from a different point of stand. And they just rolled out their model about 4 weeks ago. In fact, I was out there when they rolled it out. A representative from the governor's office was with us, two representatives, Representative Taylor, Representative Gardner, and we were all out there with the Speaker of the House, happens to be a Republican. The new Governor Herbert was there, talked to us, gave us information about it. So I mean, we had access to this. The way they came at it, Massachusetts came at it from an access model. Okay, we have these uninsured, and we need to have access. So we're going to have to fill this void and use up this $431 million. The way Utah came at it, though, is their idea was, what does the small businessman want? Okay, we know that the uninsured in that state is the young and people, they call it churn. Those are people that move in and out, and they call them, they're uninsured, but they may only be uninsured for 1 month. But they move in and out of employment, okay? Move in and out of insurance, that's called churn. And the idea was to stop the churn, to get them in more of a portable insurance, more stable situation that they could, if they wanted to move from, let's say, Orem to Salt Lake City or someplace like that, then they wouldn't lose their insurance. And this is how the Utah model came into existence. Small employers, business people, and in fact, they put their model, even it's in the economic development. It's not in the Department of Health, it's not in HSD, like it would be in our state. They put it in economic development. Massachusetts spent $25 million setting this up and had a lot of employees. Utah had $400,000 and they got 3 employees. Okay? And what they did is, with this exchange model, they were able to outsource to 2 companies the administrative part of it. It's not a regulatory, it's an administrative part. What you have with the exchange type model is not only what I said was all the insurers that are in there, you got the products, you got the cost, you want portability. But a lot of employers, small employers especially, that maybe have 2 or 3 or 4 employees, they just want to be able to say, I'm going to give this employee $100, maybe $200 a month. And I want them to go and buy health insurance. Okay? I don't want to have to mess with all the administration of it. I don't have an HR department. I only got 4 employees. All right? So the exchange takes over that administrative part of it. They take over the federal rules. There's all these federal rules in this whole process that you have to go by when you do this type of benefit programs. So they take it over. The employer also says, I only want, payroll checks come out. I'll take the $100. I want it to come out, and it's sent to the exchange. And employee A chooses Love's. Employee B chooses Presbyterian. Employee C chooses, let's say, Molina, or whatever. And that money goes to the exchange. The exchange is a premium aggregator then, and they take the money and they send it to the different insurers every month. That's their job. So these two functions, signing people up and then also the premium aggregator, were outsourced. And that's why they run a very tight ship in Utah. So those are, so you've got different states looking at that. We introduced legislation in 2007 for the exchange, all right, under the same concept. It actually got through the Senate, was moved over to the House side, and it got defeated on the House side. We did it in 2008 with different legislators, and it moved along very well too. So, and then in 2009 we decided, well, let's drop back on this. Let's get a task force started, and so we put it in as a memorial. And the memorial then, what it did was said, oh yeah, and it passed. And so Mo Chavez, the superintendent of insurance, is the individual who has to convene the task force, at which I'm on. We've had 2 meetings, and we're looking at this process. We think that the governor is very interested in it. This has to be a bipartisan thing. I mean, it cannot be a partisan issue. Health care should not be a partisan issue. So that's kind of where we stand at this. We're looking at it. We're not sure if the money is there. Obviously, we're $431,000 shortage here in the state of New Mexico. We've got a shortage of $431,000 for fiscal year 9 and fiscal year 10, and that's why they're having a special session here in October. And we haven't got to fiscal year 2011 yet, and that's what they'll have to address. But it's not going to be good. So let me kind of move from our state, the other states, to what Obama is wanting to advocate for here. And that's, there were 3 legislative committees in the House, and they came up with House Bill 3200, which is a 1,017-page bill that I'm sure you're all very aware of and have read every single page of it. So House Bill 3200, though, what they said in the House bill is this public option. You've heard about the public option, public health benefit option, okay? There's really not one health benefit option, there's 3 of them, all right? He says we need to have a benefit plan for the people of the United States so that it would be a basic plan, an enhanced plan, and a premium plan, okay? But where are we going to put this? How are we going to compete? So we're going to set up this new bureaucracy, one of the 53 that are included in that House bill. The new bureaucracy will be called the National Health Exchange. Okay? National Health Exchange. This is the new one. He got it from the Heritage. Okay? So he's trying to take information from the Heritage and modify it on a national level. But you got to understand that the Federal Employee Health Benefit Plan, the one that all the federal employees are, there is no benefit plan in there. No dictated benefit plan by the federal government. You have to have this, this, and this, and this. It's totally up to the insurers. So it's, bring us your best products and your best prices and let the people choose. But Obama, in his paternalistic sense, he feels like Americans are too stupid and we really need to have our own benefit plan, and you have to choose one of these. You shouldn't leave it to the individual. So what he did is he set up this National Health Insurance Exchange. Okay? The National Health Insurance Exchange then will say it will regulate all insurance in the United States. Okay? The commissioner of it will be appointed. The new commissioner will be appointed by the president. This is a new bureaucracy. Everybody who sells insurance in the United States will have to be part of this. You will have to have at least this basic plan within it. And if you want to sell insurance, your own insurance, you have to have at least a basic, an enhanced, and a premium plan in yours. Now, you can sell anything else, but that's what what you're going to have to do. All right. So this is very disconcerting, obviously, to a lot of individuals. So that's on the House side. Now on the Senate side, you know, the Health Committee, Health, Education, Labor, and Pensions, they're struggling to come out with their own plan. Okay, and then Baucus came out with his plan the other day. All right, talking about co-ops. Co-ops sound good, but you know, the general feeling, the smart money says it's not going to work just because there's not enough individuals involved in it to compete with the health insurance companies. And the idea, I mean, obviously the idea on the House plan is to compete with insurance companies because obviously they're not competing with themselves enough to lower the price, to improve the quality of the service. So those are primarily the plans that are out there. The concern from a lot of the states, ours included, is, and we're just sitting on the sidelines waiting to find out what happens. I mean, if the federal government says, you know, we're going to have this national health insurance exchange, of which you will be part of, and you will sell these products in here, and we will regulate them. I mean, the federal government is the regulator, a payer, and a player. And the insurance companies are basically players. You know, they'll pay out, but they can't compete. If you look at the Lewin Group information, there's 172 million individuals who have private insurance in the United States, and they say that probably there'll be a shift of 88 million of those over to the public plan. Well, that's going to put a lot of stress on the insurance companies, their employees, all the people who benefit from you know, that market. So that's a major concern. Another concern is when you've got the federal government, that's top-down management, and they're going to say what the state of New Mexico has to do, what the state of Utah, that's fine that you set up your own exchange, but you have to do it this way. We're going to tell you how to do it, okay? And you have to have this benefit plan in there, and you got to go by these rules, because we're going to be top-down management, and a lot of this is going to be unfunded mandates. So those, just giving you the information, doesn't sound very pretty, but a lot of people talk about the exchange, and what is the exchange, and what's this exchange model, and how does it really affect us in the state? We're sitting on the sidelines waiting to find out what the federal government is going to do. We can go ahead and set up our own exchange. And a lot of people are saying, well, maybe this is what we should do, because they're going to allow exchanges or co-ops. We're not sure which way it's going to go yet. But there's not a lot of support for the co-ops, even on the Senate side. And you know, where do we go from here? So I just wanted to go over that primarily and let you know where that's going. Let me just touch on a couple other things. You know, healthcare is very costly. I mean, in the United States, we spend $12 trillion a year on healthcare. That's 17% of our gross domestic product, which is $2.2 trillion. Okay. It was mentioned about, one of the things that was mentioned was about illegal immigrants. Legal immigrants. You know, where do they get their health care? A lot of them go to the emergency room, but a lot of them go to the federally qualified health centers, of which in New Mexico there's 133 of them. And I would say in some parts of our state, probably 50 to 70% of those who get health care at those clinics are legal or illegal immigrants. That's the best place for them. They can be seen by a physician there, a primary care doctor, who can give them the services that they need for, let's say, $100. They go to the emergency room, guarantee it's going to be a $1,500 bill. And you as the taxpayers are going to be paying for that. You're going to be paying for the other one too, because it's federally funded. But that's how they get a lot of their health care right now. Medicaid is another program that I just want to touch on briefly. We can talk all day on it. But the Medicaid program here in the state, we're experiencing a shortfall this year. And it's only a shortfall of $35 to $40 million, and that's the matching. For the state of New Mexico, 1 out of 4 individuals in the state receive their health care through some public financing, whether it's Medicaid or SCHIP or SCI. Okay? And that's when we as a state, we put in approximately, for every dollar we send to Washington or put into this program, we get $4 back. Okay? So if you look at the federal and the state money that we put into it, it's about $3.7 billion a year. All right? We as a state put in probably about $600 million of that. Now, what happened with the stimulus package that they had was that we would have, the stimulus package says you cannot cut enrollment, but we'll give you a little bit more money to get you through fiscal year 9. And when I say fiscal year, it's July 1 to June 30th. We'll get you through part of fiscal year number 10, okay? And that's what we're in right now. So we're $35 to $40 million short to fall, okay? But then if you look at, that's just matching money. It's really, we're about $60 million shortfall. So our Secretary of HSD, Pam Hyde, she's looking at this thing, and basically, and I go to the Medicaid Advisory Committee meetings, she says, well, you got 4 ways you can cut Medicaid. You can cut enrollment, you can cut benefits, you can cut provider fees, whether they're physicians, nurses, nurse practitioners, hospitals, okay, those are providers, or we can make some administrative changes. So a lot of people don't want to cut enrollment because of the 400, I'm just going to use round numbers, of the 400,000 people who are uninsured in the state of New Mexico, and it's the same pretty much of the 46 million people that are uninsured in the United States, half of them, half the people in New Mexico, 200,000 are eligible for public assistance, but aren't signed up. Okay? So, if you don't want to cut enrollment, if you want to increase enrollment, then you're going to have to cut the other ones. If you cut provider fees, whether it's physicians, hospitals, then those individuals, physicians, nurses, nurse practitioners, especially in our areas, will stop seeing those patients, or they'll retire, or they'll move out of state. Okay? It's the same with Medicare. So then you're going to have a shortage. We've already got a shortage of physicians and nurses and nurse practitioners and PAs and dentists and veterinarians in the state of New Mexico, whether it's, and mostly in our rural areas. We're okay to some degree in the Rio Grande corridor, like Santa Fe and Albuquerque and Las Cruces, but we have shortages of primary care doctors, and we've got shortages of certain specialists. So, I mean, the data shows that by the year 2020, we're going to have a shortage in the United States of 150,000 physicians and 800,000 nurses. So, we got to make more, we got to retain the ones we got, and all the other states, just like Texas, a lot of our physicians have moved to Texas. They got no income tax. They got tort reform over there, which has helped them significantly. But we're going to have a shortage. So now you're down to benefits and administrative changes. So if you want to change that. And what they'll do is they'll make some administrative changes, but that's only going to bring probably about $40 million in. And they'll have to look at the benefits. And I don't know if you all know or not, but whenever you take money from the federal government, they tell you you have to provide X, Y, Z. okay? There's about 7 things that you have to provide for a Medicaid patient. And then you have options. So we've got 7 things in the mandatory list. We got about 25 things in the optional list. What they're going to do is look at the optional list. Can you still provide transportation? Can you still provide emergency medical care to illegals? Can you still provide podiatrist services? I mean, we have a very generous Medicaid program here. In fact, it's more generous than what the teachers are getting or the state workers are getting. So they're going to look at that they're going to have to look at that very carefully to try to come up with it. Unfortunately, the stimulus money rolls out, it stops in December of 2011, and so they think that in fiscal year 2011, we'll have a shortfall of $200 to $300 million. Okay? And because the state's not doing well economically, we used to be able to get that from the general fund, but now that's going to be a problem too. So there's some real big problems on the Medicaid thing. So I think that's pretty much it. Oh, okay. Thank you.
Thanks very much, JR. A little depressing, but we've had Medicaid shortfalls before that we managed to figure out a way to get around and get through. But it seems to me with the stimulus money, this is a really bad idea to use stimulus money for recurring expenses, but we don't seem to ever learn a lesson on that. Now we're in for a real treat to hear from Devin Day, who is in business. She's the person who's making money and paying it to the state and the federal government so we can run all of these giveaway programs. Thank you so much, Devin. And it's your turn.
Thank you all for having me here today. And I actually do have some good news I want to share with you. On this issue, New Mexico probably does have some of the best healthcare options for people seeking care, whether it's employer-based or it's not. And I'll kind of make the case for that here, and I'll show you how it's applying to small businesses here in New Mexico, how we're able to help them, and even to a much bigger public entity. So, this is a situation for small businesses this year, after everything that's been going on. 51% of business owners say that revenues have decreased. 55% say their costs have increased. Health insurance is a big one. 47% of business owners claim they haven't paid themselves this year, so they're living off their savings. That's a big problem. 48% of small business owners do provide health insurance for employees, 36% do not. I skipped one. 68% of small business owners say that proposed health care reform will hurt their business. This is everyone's here in kind of a holding pattern, so it's kind of disappointing to see that everyone's just waiting to see what's coming out of Washington instead of actually taking some proactive action to provide a good example. We have the situation for employer-based coverage here in New Mexico. There really is no benefit to working on a cost or a premium basis, to working for a 12,000 person company or a 4-person company. I can go in and I know these rates. Immediately when I talk to someone of a 100-person company, I say, oh, your healthcare costs, I guess, are about $500,000 a year. And they say, yeah, how'd you know that? Well, all the insurance companies pretty much have the same exact product and the same exact rate. So there's really no benefit to having this big company to negotiate rates when they're all the same. Every year the premiums keep going up. Coverage is usually diminished for employees. Their exposure to medical costs is too high. And what they do is they come in and say, oh, your co-pays and your deductibles are going to be really low. But then what they do is if someone does incur a large medical cost, it leaves them hanging on the back end and paying just huge amounts every year. It's kind of like, I don't know if you guys have been to the Broadmoor in Colorado Springs. Your room key is kind of your ticket to fun and excitement, and then, you know, Sunday at 12 when you check out, you get to see what you ran up. Well, that's kind of where we are now. A lot of these employees, you know, that work for employers that have plans like this have no idea of what the costs are. They have no idea to comparison shop. They have no idea. But then they're really upset about the cost. So we need to bring in a lot of education and awareness on what this does. And it also comes into the doctors and what they charge. Self-insuring used to be an idea to lower costs. Well, that's not implemented. Now those premium rates that they charge are exactly the same as if the insurance company. So everyone's kind of caught in the same boat. So far, no alternative plan is given, and the cost shifting of medical costs just contributes greatly to this healthcare dilemma that we have. As I said, group health insurance plans have really ceased to be economically viable. That's one of our biggest questions when we talk to a business owner is, what are your 3 biggest concerns? And inevitably, one of the top 3 is always my cost of health insurance keeps going up. Again, health insurance should protect employees or anyone from high out-of-pocket costs. It should keep them out of bankruptcy should they incur those, not pay for every little thing that happens. And that's what I'm touting in New Mexico. It's actually impossible for an individual to obtain quality coverage in New Mexico, whether you're healthy, whether you have health problems, or whether you have an economic hindrance of some sort, low income. We have fabulous programs here, and that's one of the reasons I volunteer at the Cancer Services to get people in. We're immediately able to help. It's very rewarding. There's no reason really why an employer, given these disadvantages, needs to offer, or I say dictate here, the insurance an employee obtains. But an employer is a really good way to educate people on the options available and how to teach people how to use their insurance effectively. There is a new way of doing these things, and that's what I mean. I call them the New Mexico alternatives. We have the New Mexico Medical Insurance Pool, the New Mexico Health Insurance Alliance, the State Coverage Initiative, UNM Care. These are a great alternative, and actually some of these have been around since the 80s. We just weren't really making good use of them. These alternatives allow employees and individuals to obtain individual policies, and they don't have to worry about leaving anyone out. So if you're a business owner, you don't have to provide the health insurance plan. You can know that there are great programs out there that you can help your employees gain access to. Individual policies are much less expensive, and they do provide a very wide choice of coverage. People are always going to fall into 3 categories: healthy and insurable, declined, or they're covered with an exclusion. They cannot afford the premiums, but they don't qualify for Medicaid. They make too much money. And we'll go through that. Premiums for individual plans are significantly less. They're about 50% less than the group coverage. A single person on group coverage, regardless of gender, is going to be $400. It's going to be well under that for a single person on an individual plan. They are subject to underwriting, which is why the cost can stay low, because we can take people that we don't, or we can not cover people we don't want. However, almost 70% of people who apply for an individual policy are approved. So there is not a high declination rate. The 6-month pre-existing clause, which always raises red flags, that is completely waived when you show that you have proof of prior coverage with any company. So they are, they're trying to encourage people to keep insurance coverage, and this does encourage people. You don't want people just jumping onto a plan just right before they have heart surgery and then getting off again because they know that they can. You have a choice of plan, networks, and physicians that you want to go to. A program called Premium Assistance for Maternity. This kind of comes hand in hand with individual plans which do not cover maternity. For $150 to $300, you can have access to any network or physician in which you land in New Mexico, and everything is covered. Your plans, if you open them individually, are portable and they can be adjusted. So if you want to raise your deductible or lower it, you can do that. If you want to change networks or plans, you can do that as well. And having individual plans is a terrific chance to educate people on health savings accounts and how to use them appropriately. People who are declined can go to Health Insurance Alliance or the New Mexico Medical Insurance Pool. Again, all networks and hospitals are represented. They are guaranteed issued. They are very comprehensive coverage. They're even more comprehensive than the individual plans that are typically offered. Again, your pre-existing conditions are waived. You have a choice of plan. The premium is higher because you are at a higher risk. Just like if you go to a bank and you want to borrow money and your credit score is low, they're going to charge you more. That's kind of the way it should be. But if your health insurance or if your health issues improved, quit smoking, lost weight, got rid of whatever problem it was that you were able to, you can go back and reapply for the more affordable plans. And then these are people who can be people that really choose not to be covered either as well. We have a lot of younger people, but there's a UNM Care plan where they can go see any UNM Care physician. State coverage initiative, the pool, which offers premium discounts up to 75%. We had a single mom that was a client of a family of, she's taking care of 4 kids on her own. One of the kids is very ill, premium for $33 a month, and extremely good coverage. Qualifications based on household size, income, and citizenship. Again, the premium system for maternity, and there's a premium assistance for kids program for kids that also fall outside the scope of Medicaid. Again, employers that really want to try and be competitive, not just on salary but on benefits, there are several ways that they can contribute to premiums on a tax-favored basis. Instead of even, contributing costs to premiums, they can even give, contribute money to a health savings account or a flex spending account to help with some of those out-of-pocket costs. Employees all of a sudden know, because they have to write the check themselves, how much this benefit is, how much that premium is, and it makes them much more aware and much more appreciative of what the employer is doing. You don't have to worry about COBRA anymore or losing coverage. COBRA is great, but there's not a lot of families that if they lost a job can afford $1,200 premiums, so it really doesn't help anybody. But if you can keep the cost low, around $400 per family, they can probably weather that storm. And again, these strategies work for any size company or any team. I was going to make an example of a small business here in Albuquerque, but I actually decided to kind of go crazy and apply this to a state that has a significant budget deficit. This could be one we all know of. There's the 3 options for providing benefits, which I'll show you. Right now, this state is currently self-insured, meaning they pay all the costs of employees' health care. Typically, it's up to $100 or $100,000. I couldn't find that. Then the insurance company would step in. These are there's 20,000 people that I assumed on the health plan. There's over 20,000 employees. And these are the premiums that they have to, that the state cost shares with the employees. Families are over $1,200 a month. Individual employees are over $400. So these are extremely high rates. This is option A. So if the state all of a sudden hit the wall, as we heard before, and said, I really can't offer this benefit anymore because of our budget deficit, we're not going to pay the premium for it anymore. But we're going to allow you to go out and provide a resource for obtaining individual policies. Right now, the state pays $118 million per year. Employees cost sharing that with 50. And if we moved over to the proposed plan, they would have a state savings of $118 million in the first year. The premium savings to the employees by going to this individual plan is over $69 million. And that's an average of over $3,400 per employee. So effectively, they've also given employees a raise and given them a good choice of benefits. It's much more affordable. Option B would be that, they still don't offer the premium payments, but they would say, we're going to go ahead and give $500 per year per employee to a health savings account or a flexible spending account to offset some of these other costs that they have. So that would be $10 million. The state still saves over $100 million in this situation. The employees, again, still save quite a bit on their costs as well. And then option C, I took an average of saying that the state would contribute to 70% of the premiums. Employees would pay 30%. And there's still significant state savings of $48 million. And on this, I did assume that 20% of employees were declined, but on very high premium rates. A lot of people would be eligible for discounts or might opt into some other insurance plans. So I think that this is a pretty conservative estimate. This is just kind of a recap. Even with the savings, the coverage will be similar or improved. When I mean improved, I mean a lower out-of-pocket expense total. So meaning if you have a large, you're confronted with a $50,000 hospital bill, we want to make sure that your max out-of-pocket that the employee pays is well under $3,000, maybe around $2,200 or $2,500 versus $9,000 what it would be in some of these plans. The co-pays can be similar. We can provide employees incentives like contributing to high deductible or their health savings account, their high deductible major medical plans. And whenever you give someone a choice, you increase their education about something and actually the value that they place on it. So choice is very important in promoting healthy behaviors. No one's ever left behind. We've got the at-risk people on these other plans. And again, healthy people are rewarded with lower premiums. We can do all the wellness and preventative care we want, but if you put more money in people's pocket, they're usually more receptive to that. We can skip this one. And these are just a couple of my suggestions, which kind of, side of everything that we mentioned here. But I am a big proponent of the individual plans. If you put responsibility and give people credit for thinking, they are going to make some good choices when you can educate them that way. I had one HR person tell me that she just really didn't feel that her employees had the wherewithal to choose a health insurance plan, and they're teachers. So I wouldn't really feel comfortable sending my kid to a school that I'd have to pay a lot of money for each year if they can't even pick their health plan. So I like to give people credit for being able to pick this with the right information. And so again, we need to actually make sure that people who are providing information about these plans are regulated and educated as well. But you give people choice and put some responsibility on them, they take a lot better care of themselves. They comparison shop, they will not just immediately jump into the emergency room, and they will begin to understand what costs are. And then on the flip side, doctors are going to have to also understand. A blood test, if you just pay for it yourself, is $20. If you file it through insurance, it's $45. That doesn't make a lot of sense to me. But at least there are some doctors who can remove the cost of that, which right now there's not very many. So, I guess that's about it.
Thank you so much to all three of you. We appreciate your expertise and your willingness to share it with us. Are there any questions from the audience? I think we still have the mic up here if you would like to come.
I've noticed a theme here today where you all have not suggested forcing anyone to buy insurance, have you, today? Okay. And I'm assuming even when the states get involved with trying to cover pre-existing conditions, do you think they have to force others to all join for this to work?
Let me talk about the individual mandate. Because that's in all the three bills on the House side and the Senate side. All that's being proposed by the Democrats is an individual mandate. That's what happened in Massachusetts as well. If you on a state or on the federal level say everybody has to have health insurance, then the insurance companies can easily say, okay, we'll take off the pre-existing because now we have a bigger pool of individuals with health insurance. So that's an easy give for them. The harder give is if you say no pre-existing and no individual employee, or let's say no individual mandate. I'm not even going to touch employer mandate. So it's an easier give for them. I don't think it's the way to go. I'd be concerned about it. I think that there's other ways that you can encourage it, just like in Utah, and I think it's a really good model, but we need to take a look at it, and I think that they are going to take a look at it. Paul Ritzma from the governor's office who is out there with us is going to take it back to the governor. I know that he does like the exchange model. Doesn't particularly like the effects of the Massachusetts buzz, but is very interested in this defined contribution situation. So if you can get the employers to not have to deal with the administrative problems that you'd have, like an HR department, if you can have the employers, and if you get portable insurance, with individual insurance that Devin was talking about, then I think that a lot of people will go ahead with and get the insurance. There's still always going to be some churn, but it's going to be less, and that's what they're banking on. That they can get people to get insurance without forcing it down their throats, without an individual mandate, and I think that's the way to go.
Let me just comment in terms of not requiring everybody to have health insurance to get to the pre-existing condition limit. What we've thrown out there is under the assumption that everybody would not have that, but there would still be people with pre-existing conditions. That's where the government can have a role in providing some subsidies for a high-risk pool, for example, so that those people can get in if they want the health insurance. with pre-existing conditions for higher school.
Given New Mexico's budget control,
Can you let the next person and then you can go?
Sure.
There's been not a lot of talk about costs.
One of those little details that needs to be worked out, you know, like the president's program.
Hold on. We have a president who says it's going to be revenue neutral. He's $2 trillion off in a 6-month projection. That's too funny. He's going to, how it's going to be paid for. Fraud reduced $1 in 3. These guys ought to be impeached for knowing that and not having done it, number one. Number two, when was the last time the government said we're going to pay for this by recovering costs that we shouldn't have been spending? And none. And 3, mandates. There's, I think, either 54 or 57 of them. Went to the Heritage Foundation in New Mexico. The mandates in Massachusetts, when I lived there, mandated coverage for in vitro fertilization. We tried it 3 times, $25 grand in 1982, paid for by other people in the state for a lifestyle choice. Mandated by the government, podiatrists, chiropractors. Those seem to me to be the reason both that there is high cost and that there is no competition because everything is mandated. They used to work back in a law firm in New York. Proved that our client is not price sensitive. Came up with his competitor to the same penny. Why? Everybody offered a standard discount on paying 10 days early. Everybody offered a standard discount for volume purchases. If you do the multiplication, you come out to the same thing. It's not, the numbers just don't work.
You're exactly right with the mandate issue. New Jersey's got the most mandates of any state in the union, and community rating, and guaranteed issue, and their costs are 3 times what California's are roughly, you know, on an individual level. So
And that's why they don't want to sell across state lines because he's around on mandates. That's just not going to
that's why so many employers would self-insure, get out from under the state mandates.
And we're in New Mexico have about 50-some mandates, and it's broken up actually state mandates and then federal mandates. Feds say you got to have this, 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 and this, and the state then says, and it's an easy thing for our legislators to do. It's a win-win because, you know, I got this special interest group that comes to me and they say, I really want this to happen. And the legislator says, I think I can make that happen. And so, you know, it's, and it happened. So they had one more mandate on it. But it's, you know, it's costly. Now, some of the states are looking at mandate light legislation so that they are able to sell insurance for sort of a stripped down model, okay? We in the state of New Mexico have statutory legislation, New Mexico Medical Minimum Health Act. I can't remember exactly what the terminology is. So we have a minimum amount that we have to provide in the state of New Mexico. It's sort of, unless we want to change that, I mean, if we change it, we can go into some light products, but that's what a lot of the other states are looking at as well.
Questions for Dr. Gabbard. In Santa Fe, of course, you know, we've had some doctors speaking out lately. You're one of them. The Tea Party, we had 2. And then there was a physicians-only healthcare forum. I didn't attend that, but Dr. Behill spoke at Republican County. And it was obvious from her comments that patients are asking doctors
Thanks, Cheryl. I'll take the second one first. On Medicaid. Medicaid is basically a program for the poor, the children who don't have, the poor, children who don't have insurance, and disabled. Okay? I don't believe that there's going to be any Medicaid cuts for the disabled, even though cost per year, they're the highest. They run usually $16,000 to $17,000, and Robin can always correct me all this information. She knows it by heart. Whereas children are pretty cheap to get insured. They're about $3,000 a year. Pregnant women, they're not too expensive either. So I mean, but they have to look at all these options. I don't think that there's not going to be any cuts on probably the disabled. But they're going to have to look at those benefit options that they currently have and decide what they're going to do with that. I have no idea what the governor and Secretary Hyde is proposing at this particular point. But I'm sure they're caucusing and trying to determine what's going to come out of this, because they've got to find some ways to cut money. As for the physicians, it's an interesting point. Most physicians are just trying to get through the day. Okay, see their patients, hopefully they get paid, and they're just trying to get through the day because they'd like to do some things with their family as well. And so they haven't been as intimately involved, whether it's the state of New Mexico or on the federal level. I think you probably know that probably only 25% of the physicians in the United States belong to the AMA. So what comes out of the AMA is not totally representative of what physicians would like to see happen. But they are getting, even Santa Fe, which has a plethora of Democratic physicians, are really kind of getting involved. And I'm president of the Santa Fe County Medical Society. We had an interesting meeting yesterday, I believe it was, or maybe it was the day before, for lunch. And the malpractice issue was brought up, and we had probably 40 physicians there. And we got to be around Robin talking about it. Alex Valdez, who's our CEO of Crystal St. Vincent Regional Medical Center, was there. And so, it turned out to be physicians are getting pretty interested. And as Devin said, it really comes down to education. I mean, we have, and I'm not just saying New Mexico, but throughout the United States, we're health illiterate because we don't know somebody else has been taking care of it for us. But we need to get the patients, the consumer, responsible enough to ask the questions, and we've got to get our physicians responsible enough to say, you really don't need this medication, maybe this generic would be better than this one, and let's try to save you some money here as well. So I think there's a big, this healthcare issue is very timely, and a lot of physicians are getting excited about it.
Everybody has a question. What happens if they develop a program, collect money for it, and then use it through the general fund? I'm not sure that there's a lockbox mechanism around this proposed program. And if there is, I think that there would be an absolute taxpayer revolt of some sort if they unlocked the lockbox and threw it into the general fund. That's about the best, but no, we haven't considered, what might happen there. But certainly, I can see one of my, think tank people sitting here with his eyes and ears starting to smoke at the thought of touching the lockbox.
Well, they did that with Social Security.
I know that, yep.
This doesn't work. You'll have to pardon me, I missed the first half of that talk. I was in the education forum. I'm dismayed at lack of passion here about what's going on. I'm scared to death of what's going to happen to us when they change this health insurance system. It seems to me that any government plan is a government plan, whether they get rid of this government option or not. They're going to tell the insurance companies what to do, and we're going to get stuck. It seems to me that you people, and you're all, I admire you. You're doing a good job, you're well-meaning, you're intelligent, responsible people. Maybe too damn responsible. You know, I'm really sick of what they're trying to do to us, and I want to let you know that we want people like you to speak up for people like us that are scared to death of Obamacare.
I don't think the intent up here was to show a lack of passion or even to acknowledge that something has to happen at the federal government level. You know, I think what we've all proposed to do is do something within the constraints of the existing private model to make it better. There are some flaws in the private model as it exists currently, and we'll certainly work very hard to try to get those things accomplished and this kind of information communicated to the extent that our congressional delegation in Washington, D.C. will listen to us. You know, our congressman from northern New Mexico, Congressional District 3, he had a telephone conference call with screen calls for our part of the state. And he had a completely structured, meeting in Santa Fe that some of y'all may have gone to, that screened and had a healthcare panel with him. He didn't have JR with him, or Devin, or somebody who might have a point. But, there's a lot of passion, and we certainly, nobody's, supporting any kind of government option. Just trying to deal with the potential fallout if there is one.
I said one more thing and I'll be quiet. I'm not worried about the government action. I'm worried about this whole government thing. No matter what it is, it's going to be terrible. We can prove it 10,000 ways. $2 trillion deficit, the government never does what it says it's going to do, blah, 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 blah.
Right, and I think one of the trends that I've been seeing lately is once we are knowledgeable about some of the programs, especially like what I talked about with New Mexico, I have seen a lot more interest from the business community in making sure that their interests are represented here, and not just being sitting ducks waiting for something to happen, but I really do advocate people trying to take a more proactive approach, and that means, doing things like we talked about today. I think a lot of it, you're right, and it does need to come from not just individuals, but it needs to really come from the business community right now, which the business community has been horribly underrepresented in everything that's going on. And small business is the backbone of this country, and again, we have to do things that are going to protect them and help them to flourish, and putting mandates on them and things like that are not going to do it. But allowing them to become educated about the programs that we have, about different ideas about providing care and progressing on what we can do that's going to help the bottom line for companies is very important. But you're right, we have to stir some interest within a lot of the different communities.
Let me just say something. I really appreciate what you're saying, because everybody out there is feeling the same thing. And our congressional delegation ain't listening to us. Not a bit. And we got to vote those bones out, okay? We got to get John Burrell in here in CD1, and Steve Pierce down there in CD2, and we've got a candidate, Adam Kokish, in CD3. And they're not listening to us. And we write them letters, and we try to get in on their, conferences, and it ain't happening. And everybody ought to be passionate about this. Healthcare is personal, okay? It's not like buying a car or something like that. This is personal. And we have a big distrust of the federal government, and people should get passionate about it. And it's okay. It's okay to do that. We're just trying to give you information up here to tell you what's going on, but we have a lot of passion. You know, I don't want the federal government involved in my practice. I know that if public option goes through, it's going to be a single payer, it's going to be limited access, it's going to be rationing of care, and it's going to be cutting Medicare, it's going to be cutting Medicaid. That's the only way you can do it. And so we all need to get passionate about this because this is important. Thank you.
I was wondering, nationally, is House Bill 3400 speaking of similar methods to what you all are discussing here?
We didn't talk about 3,400, but we did talk about 3,200 on the House side. On 3,400, I think it's only 200 some pages, but it's brought forth, or we try to bring forth on the Republican side. I'm not as familiar with that one though as I am, but you know, it brings forth choice, access, portability. I mean, these are all things that are very important to us. You know, I think that we have an opportunity. I'm going to just say something about that was mentioned on the Health Insurance Alliance by Devin. We have got a lot of great programs here in the state of New Mexico. We got a lot of great public assistance programs in the state of New Mexico. And one of them is the Health Insurance Alliance, started in 1994. But it's 15 years old. It's more paternalistic than I'd like to see it. And the question is that we're asking, a lot of us, you know, from the governor's office, legislators, can we morph that into some type of exchange and bring it into the 21st century? Or should we start with a whole new game plan? So that's one of the things that they're looking at right now, whether that may be morphed or not. Yeah, I'll talk to it. I live in Santa Fe, you know, I mean, it's a hotbed of different types of medicine rather than Western type medicine. I mean, we have a lot of holistic, acupuncture or I mean, there's just a varied amount. And I think that that's being more accepted throughout the state, throughout the nation. So I can't speak specifically. I'm trained in Western medicine, so I'm a diagnostic radiologist. I'm a guy who looks at things and finds things, but I don't treat people generally. But I think that it's, especially up in Santa Fe, I mean, it's a different place to live, a city different, so to speak. But I think that it's being looked at in different ways.
It's not getting reflected in any of the discussion by either side.
Well, it doesn't really come under the umbrella of insurance because a lot of those practitioners don't accept insurance.
Yeah, well, it comes under the umbrella of wellness practices.
Right.
Yeah, and Bill, there's certainly a number of these types of alternative medicine programs and practitioners are covered, some by state mandate, but some of them by the fact that, you know, particularly acupuncture is a standardly, I think, recognized form of anesthesia now in certain procedures, and certain, you know, procedures that acupuncturists will use are appropriate in muscle and those kinds of things. So there is some recognition of the value of those programs within insurance companies. But a lot of it is driven by mandate. And you know, some of the mandates mandate that an acupuncturist, you know, be able to perform brain surgery virtually, and overstating the case. And that's where the mandate issue at the state level can get a little more praise, and something Texas did with their workers' comp program is they made chiropractors physical therapists as opposed to case managers. When they did that, shut down a lot of fraudulent and very abusive chiropractic practitioners in the state of Texas. We were running a scam. We were taking a case rate, seeing a guy one time selling pills out of there, taking pills from somebody and selling them to somebody else. There's a lot of weird stuff going on that happening there. With regard to the direct-to-consumer advertising for pharmaceutical companies, it's a great opportunity for the administration currently to have gained some kind of concession on direct-to-consumer advertising in the $80 billion that they're going to help the seniors with their donut hole on Medicare Part D, etc. And nothing happened about that. And you're right, that's an issue that probably ought to be addressed in one of these programs. And it's a valid point.
One last question.
Conservatives like to get into discussion about personal responsibility, but there's personal responsibility to stay healthy, particularly in light of what's going on in the world. And there are plenty of leaders out there that can lead the way. Larry Dawson right there in Santa Fe just switched over for Andrew Weil out in Arizona to do some newsletter, and I invite you to newsletter to find out what's going on. Eventually, training doctor that does suddenly turn holistic.
Andrew Weil was the name that he's talking about in Arizona that's gone from traditional medicine to holistic.
I think we have time. I think we have time for one last question.
I know time is short. I didn't realize it was 5 o'clock, and the conversation seems to have come to what I have come to, and that is, it seems what we have to recognize is that we need more practitioners of healthcare. And I don't know why we stay away from this word, but a 2-tiered system or a 3-tiered system. One of the reasons that the legislator in Canada had to come to the United States to have for breast cancer was because they just had a single payer, single level of health care. And that was something that she had voted for Canada. So she had to leave Canada and able to get to the 2nd tier. So since we're looking at more practitioners, perhaps we could localize practitioners instead of doing it after they finish medical school where they're qualified to do everything. If we could go ahead and specialize at a younger, earlier entry point, maybe in 2 years you could actually have people that can look at and diagnose specific problems. You can even have people in a clinic. I envision, for some reason, 8, 4 to a side, a medical doctor in between, and younger practitioners doing heart bypass surgery, so to speak, if that's what they're diagnosed for. Yeah, but you may blink, but a medical doctor is there on line. And I would rather have a heart bypass surgery done by someone who does 2 a day for the last 6 months than a doctor who's qualified or has the mandate to do it, but yet only does 1 every 2 weeks. I think the success ratio would be much higher in the clinic where people were doing it on a regular basis. And I only throw that out perhaps to shock you. But the point is that if we're going to give everybody all they want, then we are going to have to increase the number of people who we say are qualified to provide those type of surgeries. And I know that practitioners have an idea of protecting their turf. My son's an optometrist. Here in New Mexico, optometrists are protected from the rest of the states. I don't know if you realize that. When you go to an optometrist, you pay more than you do if you went in another state. And the reason is because they do their licensing practice or tests in September. Well, when a student graduates in May, and he's been in medical school for a number of years, what's he looking for? He's looking for a job, isn't he? And he's not going to come to New Mexico if he can't even take the test until September to be certified. So that's okay, but it's just an insider view as to how we protect our own in our own professions. Doctors protect their own, lawyers protect their own, everybody protects their own to the detriment of society, basically. So that's probably all I
comes down to shortages too. Again, we've got a lot of shortages for physicians, nurses, nurse practitioners, PAs. I mean, if you look at the University of New Mexico, we only have one medical school here. University of New Mexico started out 30 years ago, 75 graduates, okay? Then they went to an MBA program a few years ago, now they're at 100. I would advocate that that needs to be at least a minimum of 150. We need to double our nursing school graduates. They need to look at a dental school. They need to also look at down at New Mexico State University Veterinary School. But economic development is also part of our rural areas. We're a very rural state. I mean, we're the size of Germany, but we're a very rural state. So for every practitioner that goes into a community, 7 jobs are created, at least 7 jobs. So if we're not there taking care of it, let's say Fort Sumner lost their physician, okay, and then they had a nurse practitioner come in, and then they lost that nurse practitioner. Then I mean, you don't. If you lose your practitioners, then you lose your hospital, and once you lose your hospital, then you lose your retirement. Because people don't want to retire in a place where they don't have a hospital or close to a hospital to have happen. Somebody loses a finger in an auger, a farmer does, they got to travel to Roswell to get the finger sewed back on. So I mean, it's an economic development, and you lose the population, and you lose your tax base. So I mean, it all plays. That's why we need more practitioners in the state of New Mexico. They can do a lot of things, just as you said, and I think that's important. I mean, I graduated from the University of Indiana, okay? We had a graduating class of 400. Now, that was pretty big, but the legislature decided a long time ago, if we graduate 400, then we know that a certain percentage of them are going to stay in our state, 60%, and they're going to take care of our population, okay? So that's really what it comes down to. It comes down to numbers. And if we don't do it, then somebody's going to take them away from us, and then we're going to be in more dire straits. Thank you for bringing that up.
Thank you all for being here and listening to this interesting discussion. I do think that all of us have a passion for making sure that our healthcare system stays the best in the world, that we're able to offer the best care, and that we can offer it at reasonable prices. Thank you to each member of the panel so much for the time that you've spent putting this together. I appreciate it, and I know the audience does too. Tomorrow morning we will start at 9 o'clock. I urge all of